We now have an important keynote address on probable intensity of Omicron infection on India in the face of over 100 crore COVID by Professor Dr. Joe Thomas, who will be in conversation. Dr. Joe Thomas is an accomplished institution builder, academic, diplomat, and a global leader in public health rights and social development for over 25 years. He has worked as the executive director of an intergovernmental organization of 26 governments, partners in population and development, or PPD. In his capacity, he has represented PPD at the UN General Assembly in New York and the World Health Assembly at Geneva. At the UN General Assembly, he spoke on antimicrobial resistance, sustainable development goals, migration, and refugee compact South-South cooperation. He was Pro-Vice Chancellor, the founding director, and professor of social determinants of health and social policy at the Jodhpur National University. He's also a visiting faculty of the School of Health Sciences and Social Work, Portsmouth Bajwaya Center for Global Health, Population and Policy, University of Portsmouth, United Kingdom. Currently, Dr. Thomas is working as the Professor of Public Health and the National Course Convener at the Institute of Health and Management in Rosanna, Victoria, Australia.
One of my main studies about access to healthcare and inequity in healthcare and how to deal with it. That's one of my major research as well as my action. And incidentally, I work as advisor to the Ministry of Health in East Timor. So when the East Timor government got independent, I was there to assist the government to form the Ministry of Health on behalf of Australian government. So I worked on both theoretical level, academic level, as well as practical level. So this health inequity plays on national level and global level. The best example is access to vaccine, the COVID vaccine. In some countries, they have, for example, Australia, about 90% of the people got access to vaccine, whereas in some countries, 4%, 5%. But the COVID pandemic, one case anywhere is a COVID case everywhere. So this is one of the manifestation of health inequity. So COVID pandemic that amplified that health inequity, particularly in the area of accessing vaccine. But in Indian context, it's a magnificent achievement that India reached about almost 116 crore vaccination, and within 60%, the span
60%, yeah, 60%.
Right. Yeah, but that is within the span of less than 1 year. So that's from a public health point of view, that's a significant achievement. But from the COVID pandemic, that alone will help us, that we have to look at carefully. So I'll get into some of the analysis of that. Okay, we have a significant achievement when we look from a 2020 March to 2021, end of 21. So today we are much more prepared than 2020 March when the lockdown was declared. And we have a significant understanding about how the COVID pandemic works. And we have a significant investment in the area of diagnostics, treatment, and a significant number of doctors, they know how to deal with a COVID patient. This was not the case about a year and a half. So within the short span of time, we expanded magnificently. So this is my introductory point I want to make.
So, sir, when you say this health inequality, so what are the extremes you see, like from have-nots to haves? What are the extremes you see in the current scenario and on the global front?
The global front, some countries, they have a phenomenal access to vaccine. They have first dose, second dose, and they have booster dose. In some countries, they haven't even had 4%, particularly Central African region, they haven't even reached 10% of the vaccination. The thumb rule is that any country, you need about 40 to 50% of the population should be vaccinated to act as a kind of creating a herd immunity. So that's the cutoff point we're looking at it. The global level, we had to look at about 40 to 50% of the population should be vaccinated, preferably first and second dose. But even in the case of India, we start talking about the booster vaccination. And this is going to be accessible to only few people. So the COVID pandemic, vaccination is an important tool for the prevention and control. But that's not the only thing. We have other, the public health intervention like physical distancing, hand washing, and the basic hygiene practices. So this is the dynamics I put it across. To begin with, the issue of health inequity should be looked at upon when we address the COVID pandemic. And also, if you look at the vaccination in the Indian context also, our vaccination focuses on 18-year and plus. The children are left out. The Omicron is focusing, there is a propensity towards children's infection for the new mutation. So this is some of the areas of concern we have.
Got it. So what, in your view, is leveling up health? What is your view, in your view, is the solution to reduce health inequities?
One of the lessons from COVID pandemic is that how we look at disease, how we look at health. So one major conceptual shift of understanding health should be understood as one of the major health security, the concept of health security. Health security should be considered as a national security. Or health security, the security of the people should be equivalent to border security. So how we look at national defense, national security, and we should give same importance for the human security and health security. This is one of the shift in changing is occurring. That means our investment in healthcare should be tremendously, it should be improved, because right now, if you take the case of India, it's approximately 2% of the GDP. And it has to reach some level of health implication, some basic level of health equity, we have to immediately increase into 5% of the GDP. And eventually it has to go up to 14%, 15%. If you take the case of example of Sri Lanka, one of the best example of health investment, they went up to 14% of the GDP for health investment. So unless we look at primary health care, unless we look at health for all, unless we look at universal health care, and this is a political question, I'm not denying that, and it needs to be looked upon. The COVID pandemic is a very important, it's a reminder for us. For example, the amount of the economic impacts, it's not the health alone, because the lockdown for 2 years and probably trillions of rupees worth of economic progress lost. So opportunity cost of health, lack of investment in health is phenomenal. So the lesson to be learned is that we have to boost our investment in diagnostic basic care and also access to healthcare, strengthening our primary healthcare centers, and also investing in looking at the labs which will follow, which will carefully monitor the infection, which way it is going up, and also looking at the genetic mutation of the virus itself.
Very well said. You also said learning to live with the virus long term will require change in both mindset and policy. So can you please elaborate on both the aspects, like change in mindset, what do you mean, and change in policy very specifically?
See, as I mentioned earlier approach towards controlling COVID is the zero infection. Let's completely block it so we protect ourselves. But now the shift is that let's find a way to live with the virus. So this is one of the major shifts, complete elimination of virus to living with the virus. So this is one of the more public health oriented thing. We have to look at how to strengthen our healthcare system, because we know that one of the unique nature of the infection is that even though it's highly virulent, the number of hospitalization, that's a key issue. Now, many people say that the best way to look at the COVID pandemic is look at the number of hospitalization rather than the number of cases reported daily, because the number of cases reported and the number of hospitalization, there is a great variation. So this is the shift in, then what we need is we may have to suppose we invested in the healthcare system and we kept the entire country open. So these are the hypothetical scenario, we may say that. But locking down, we have to pay a huge financial burden. That financial burden, to recover from that financial burden, it's going to take several years. We don't even have a clear assessment about what is the financial burden, what opportunities lost. When you look at the opportunities lost, education is the biggest impact. Children's education was lost for 2 years. And we don't know how that is going to impact on the cognitive development of particularly younger children. 2 years loss in cognitive development and skill development of children. Whether this foundation loss is going to build up on, we don't know that. But probably suppose we would have expanded our healthcare system. Anybody coming to the hospital, we should have a system to take care of them. Because we know today the COVID pandemic is an infection of the lung disease. It's a lung disease. So what technology we could expand it to ensure that lung disease should be, the treatment protocol should be strengthened, because we also have to remember India is also leading in the TB, another lung disease. So there are comorbidity issues are coming up. There are other infection already existing that is coming up and playing with the COVID pandemic. Diabetics is coming up. And also the Indian population, the older population. How we deal with the older population becoming an important issue, because the older population is looked upon just as economic burden of the society. Their cultural contribution, social contribution, and the symbolic contribution, it's not taken into consideration. So what we did is that in the initial part of, we sacrificed many older population which we could have saved. So these are the mindset I'm talking about.
Right. So one very important point you just raised is living with COVID is the new mindset. But the challenge what we see is living with COVID with fear and anxiety. That is one of the biggest challenge which societies are facing. And you also said that if we change the whole goalpost and we say that it's not reporting the number of cases but the number of hospitalization. So do you think that this will be able to handle and tackle, because whether it is Omicron or other new variants, we have seen the hospitalization rates going down. So this can be one of the ways which governments, particularly Indian government, should look at.
See, when we look at the COVID pandemic, we are looking at there are several variants of concern. It's not only the Omicron we're talking about. We had an alpha variant, beta variant, gamma variant, delta variant, now Omicron variant. And we look at the genetic mutation, we're talking about almost more than 1,300 genetic variations. So this is the magnitude we're talking about. And also COVID pandemic, we talk about long COVID. After the infection also, you had to live with the side effects, after effect of that. So cumulatively, the COVID pandemic is really, we are talking about a syndrome. And in syndrome, we are living with many variants. And all these variants exist. Even if we talk about Omicron, Delta is existing. Delta didn't go away. And also Beta didn't get much media attention. Alpha didn't get much media attention, even though both of them are declared as variant of concern by WHO. So how people understand the infection also varying. Now, the moment Omicron came, there is much more media attention than Gamma, Beta variant. So this is the interesting part of it. And also we talked about the fear. The fear we talk about March, January, February of 2020, and today there is a significant variation. So earlier people are really locked down, and I see in Pune and Mumbai completely the streets were empty. And for days together, the transport system is completely standstill. So that way, that fear and today's fear, the shift moving towards that we have to find a way to live with an epidemic. And through various ways. One is a lockdown, selective lockdown. The intensity of lockdown itself changed. So this is the one thing. But when you talked about, we have to remember the stigma attached to the people infected with the virus. And the Indian context, there are other stigmatizing infection. For example, take the case of HIV infection. AIDS infection also, we know that HIV infection also, there are viral mutation. HIV-1, HIV-2, then subtypes A, B, C, D of HIV-1. Subtype 2 also ABCDs went on GFG. The variations of subtypes went on significantly. And today we have there is a subtype of epidemiology is coming up, the genetic mutation related epidemiology, viral epidemiology is coming up. So our knowledge base also impacted by the COVID pandemic. But what is remaining today is the fear is changing dramatically. Our skills of the doctors change dramatically. the policy shift is changing dramatically, but still there are certain population groups are left out, and still the stigma is significant. Many doctors were chased out of their own residential colonies, which never happened in earlier. Doctors they had a very higher level of social acceptance in the society, but the COVID challenged even that.
Got it. No, very right. So, one very important thing is particularly in Omicron time. What is overall we have seen in US, in European countries, now also seen in India, is about vaccine hesitancy. So, how do you see this is impacting management of COVID-19, particularly when the new variant of concern, Omicron, seems to be spreading much faster than anticipated, and things are going out of gear, particularly what we see in South Africa, UK, Norway, and these countries?
See, one is how do we communicate about COVID pandemic is a significant issue. And if you look at the British Medical Journal or that day for yesterday's publication, Omicron is causing more infection but fewer hospital admission than Delta. So this is the data from South Africa. I say that there are more infection rate because one person can infect another 3%. And also in the laboratory condition, there are about 70% infection rate than the Delta. But at the same time, in the actual condition, we are noticing about 10% of the infection. So this is the lab test basis and the actual infection rate. There's a variation. But also when you look at the issue of see, one thing is very clear. We have the data says that the public health and social measures and also infection prevention control measures are actually working. So this is very, very clear about it. And as a policy level, probably we have to look at our lockdown response, because we cannot lock down endlessly because economic burden is so phenomenal. And I don't think that people can afford to take one more lockdown because the economic resources are so much stretched. So we have to focus on the vaccine and dealing with the vaccine hesitancy and also other preventive measures, the basic preventive measures like reducing the physical distance and also avoiding the larger the crowding, looking at the ventilation or the confined settings, and also how you provide treatment for the people infected. And when you talk about vaccine hesitancy, the vaccine hesitancy is not only for the COVID pandemic. We have many other vaccines. We know that about 25 vaccines we are using. But the vaccine hesitancy, it comes on various forms, various reasons behind it. Dealing with the vaccine hesitancy should be as part of our prevention effort and also health communication.
Got it. So, very rightly. So, when we talk of Omicron, so much of we have a 1 hour session after your keynote address and our discussion, and is focusing on various aspects of Omicron. So, you have been a global person sitting in Victoria, know India so well. You have lived here. You have been teaching here in World Peace University, living in Pune. As you said, you were stuck for 2 years in Pune. So, what do you think from India perspective? What is your, first of all, Omicron is the way it is spreading, it's likely to spread very fast in India. And what will be the impact? Like, there are two things, what generally people are understanding from all the media reports and expert reports. One is that, yes, it is going to spread very, very fast. In fact, three things. Second is that it is not that fatal, or hospitalization or mortalities will be not compared to, say, other earlier variants, particularly Delta. And third is that that's what the Indian government also took a call, that probably boosters will not do immediately. First, we need to do the first round of vaccination, then boosters. But there are also reports that boosters are not working, or even the normal vaccines which are available may not work that well for Omicron. So, what is your view on this, particularly from Indian perspective?
See, when we look at the Indian the COVID response and also COVID pandemic spread, there is some interesting scenario. There is a variation between the states. Some state there are more infection, and some other state there are lesser infection. And many people asked about how to explain it. For example, take the case of Kerala, one of the highest reported cases of COVID pandemic. Whereas if you look at other states, which we assume that maybe health systems are weak, but there's a huge variation between the states. So this is the one thing we have to keep in mind. This probably because of the demographic variation. Because if you take the case of Kerala, 11% of the population is 60 plus. And also if you look at the epidemiology of the infection, there is a positive strength for the younger population. And the children are less infected. And also some hypothesis says that women are less affected. So these are the general hypotheses. And also one thing about COVID pandemic, we have very limited data on the very finer aspect of the infection. So many of our discussion is based on assumptions and hypotheses or lessons learned by dealing with other infection. So one of the hypotheses why India didn't hit much is that it's a relatively younger population. Relatively, this may be one of the issue. I mean, why didn't hit like maybe if you take the Italy and most of the European countries are older population is more. The population pyramid is basically shifted towards older population. But whereas India is still a younger population, the young population might have helped us to act as a barrier towards the rapid spread. This is maybe one issue. So even the Omicron, even though there is a reported data saying it is also affecting children, but we don't know in the Indian context to what extent the severity for children. Is it because of the general population getting herd immunity and there is some level of herd immunity is coming up? So then the newer population, that the younger children and adolescents are getting infected. This is the one thing we may carefully monitor. To what extent the children are getting infected, particularly the schools are being opened. Because children may not get infected, but children act as a carrier. In that process, they may infect their parents, their staff, when they travel. So this is one of the dynamics. Impact of COVID pandemic on children, we need to monitor very carefully because the amount of data we have to make a very absolute prediction is very limited. Because also we don't have an extensive vaccination program with children as well. So these are some of the dilemmas we have because we don't have clear critical data to make an absolute prediction. The assumption and hypothesis is that number one, younger population may affect as a barrier towards the rapid spread of COVID pandemic. And second, we are almost hitting about 40 to 50% of the vaccination soon. That may act as a herd immunity. And also people who are infected and get cured, they also acquired the resistance. So we have a significant number of people with the herd immunity. So that may also act as a protective barrier for us.
Right. So though there's so many questions and we'll keep taking up in our upcoming sessions whenever you are available. My last question is that, and very relevant in current scenario, is you have also done some good work on AMR, antimicrobial resistance. It's also said that AMR is the insidious and silent pandemic in making. Already a complex challenge, AMR now needs to be addressed in a challenging healthcare landscape. What are the changes due to COVID-19 in terms of antimicrobial usage, infection prevention, and health systems, and how they affect the emergence, transmission, and burden of AMR?
See, there is a parallel because the COVID pandemic is a viral infection. But microbicide, we are mostly talking about bacterial infection. But one of the major characteristics of Indian context of the health-seeking behavior is that many people tend to take antibacterial medication over the counter without a physician's prescription. So non-prescription, self-prescription of antibacterial, antimicrobicide is a major issue. Because people, they themselves say, okay, 5 days I'll take a medicine, 7 days I take a medicine, or I'll just finish the one strip. And pharmacists said, okay, take one strip. So this way, the antimicrobial treatment may be suboptimal. This has led to very significant microbial resistance. And this is manifested mostly in the case of a TB treatment. But the Indian context, again, another dimension is that this has went into animals. Animal feed is somehow contaminated or maybe deliberately introduced by antimicrobial medication to fatten the meat industry. There is a link between that. So that further eating And also the veterinary medicine also, it seems they're using more than what is required in antibacterial medication. So the Indian context, the antimicrobicide and also antibacterial resistant and also it gone beyond the critical resistance level. And this is going to be a very significant thing. And during the lockdown, it seems people are using, they just, because many people, they confuse between viral infection and bacterial infection. For the fever, you just take a antibacterial, or maybe just take some, non-prescribed antibacterial medication. So these are some of the issues in the pipeline which we may have to carefully look at AMR point of view, because prescription and the use of medicine without prescription. And this is very significant in Indian context. And probably we had to look at the pharmacists and working with the pharmacists to educate them about the significant, they know most of them what's implication of AMR. But stopping AMR, probably we had to look at working with the pharmacist and also significant public health education and monitoring the implication of antibacterial, antimicrobicide resistance bacteria emerging on various sectors and various disease profile.
Thank you so much, Professor Thomas. It was indeed a pleasure interacting with you, though because of time limitations, a lot of questions we are live on our YouTube and Facebook channels, which are very widely seen across the globe. And there are many questions which you would like to take up in our future sessions. Particularly, you spoke on the comorbidity, the tuberculosis treatment, the AMR and tuberculosis, and how COVID and tuberculosis have a link. Those things we will definitely like to take up. You have also done good research on migrant population. There's big stuff happening in India, but that is the reversal of migration as well as migration. Both the things we have seen in extremes during COVID. Those all other issues also we'd like to have answers to. But we have, because of time of limitations, so thank you again. We have with us the next session distinguished panelists. Especially, I would like to mention about Professor C.S. Pandav, Dr. C.S. Pandav, who just recently got Padma Shri in last year for public health. He has been our patron and guide for the last 2 years. In fact, for last more than 10 years, 15 years, since his time when he was heading AIMS Community Medicine, he has been at distinguished positions and a vocal communicator and a vocal propagandist for public health interventions in India. He's been the true leader. So he's joining us. He agreed to join us in the next panel, which hand it over to Shankar sir to start the next session. And again, thank you so much to you.
Yeah, I just wanted to acknowledge Professor Pandav. He is my guru. We had long interaction in Pune. I had opportunity to look at. He is ideal man of India because he is the one who actively lobbied for iodized salt, and he got a testing lab itself. And also, let me thank Srivasuji and Shankarji, and also the foundation, the HEAL Foundation, for inviting me. Thank you very much, and look forward.
Shankar sir is also has a lot of questions related to Kerala, but of course he'll take up in one of the future sessions.
Sure, all right.
Definitely connection of Kerala.
Yes, right. I have been having a ringside view of what is happening in Kerala, so probably the next session I'll take that. Thank you very much, Professor Thomas. Thank you, Sudeep. It was an excellent session, quite informative, and now we move on.